A warm welcome to today's short session on the management of reflux-like symptoms in the pharmacy setting. My name is Pali Hungin. I'm Professor of Primary Care and General Practice at the University of Newcastle in Northeast England. The learning objectives of this session are, firstly, ensuring that the symptoms being presented by the patient are indeed genuinely reflux-like, being aware of the main causes of reflux-like symptoms, being aware of non-pharmacological approaches for the management of reflux-like symptoms, and reviewing and being aware of first-line therapies for the patient. What appears straightforward is often more confusing than it might seem. The chief symptoms to watch for are, of course, heartburn and regurgitation. Heartburn is often described as a burning sensation in the chest and upper abdomen, of course not associated with exertion, because that might indicate a different problem altogether, possibly even a cardiac problem. Heartburn is a confusing term in some countries because the language that's used and the descriptions vary from culture to culture and from setting to setting. Nonetheless, on specific questioning, the key symptoms are a sensation of discomfort behind the sternum or in the area above the upper abdomen. Of course, these symptoms are often associated with regurgitation. Regurgitation is described as a sensation of fluid or stomach contents refluxing back from the stomach area into the esophagus, often towards the back of the throat. Reflux-like symptoms are, of course, often worsened by bending, lying flat, and at night during the sleep position, when the gastroesophageal valve doesn't control reflux as well as it might. Symptoms, of course, can be worse after meals, particularly large meals, and if large amounts of fluid have been taken with meals. This increases the intra-abdominal content size, and the level of pressure in the abdomen can cause these stomach contents to reflux and to give these symptoms, sometimes very unpleasantly, to the individuals. A big and reasonable question to ask is acid the main problem in gastroesophageal reflux disease? Well, if we call it reflux disease, then it's entirely possible that acid has been causing inflammation, erosions, and other problems at the lower end of the esophagus, in which case, yes, GERD is a specific entity. But as far as the symptoms of reflux are concerned, the causes of these symptoms are often not very clear. Actually, in cases that have been studied, only a proportion of patients have been found to have acid as the main component of their symptoms. In fact, probably no more than 20 or 30% of people presenting with reflux-like symptoms will have had acid as the main component of their problem. The reason, of course, is that the refluxate, in other words, the material that refluxes from the stomach up into the esophagus, consists of other things, mainly food contents, which means liquids and other solid particles in the stomach, as well as enzymes like pepsin, and of course acid, as we've mentioned. So the symptoms may not be due entirely to the acid alone, but they may be due to other causes, such as hypersensitivity of the lower esophagus, which of course may have been started by frequent exposure of the esophagus to the stomach contents. The point of this particular description is to indicate that acid alone is not necessarily the cause of the problems, and therefore suppressing the acid alone may not be sufficient to provide relief to patients. At the same time, when people present with these symptoms, we do have to be careful for other red flag and dangerous problems, such as, of course, dysphagia, which means food sticking, which might indicate that there is a blockage due to some kind of tumor problem or a narrowing of the lower esophagus, bleeding, weight loss, new onset of symptoms in an older patient, and general ill health, and of course drugs that cause gastrointestinal symptoms all have to be considered as possible other causes of these symptoms. So what are the main interventions that we can use to help our patients with these symptoms? How can we prevent them from getting these symptoms? And if they have them, and even if they are on treatment, say with a proton pump inhibitor or some other acid suppression medication, what can we do to help them along? Well, a review of all the usual things, which I'm sure you're familiar with. First of all, advice about losing weight if people are overweight, particularly if there is a great deal of abdominal obesity. Smoking and excessive alcohol will cause problems. Tight clothing can worsen symptoms. It's amazing how people will wear tight belts and other clothing which compress the abdomen and may cause reflux from the stomach into the esophagus. Avoiding fluid with meals is a good plan because excessive fluid will cause reflux to occur. Avoiding eating after a feeling of fullness. We're all guilty, I'm afraid, of eating rather more than we need to, especially when you reach a point where you think you've eaten enough. Well, that's a remedy that could be easily effected if only we could get through to ourselves and to our patients. Avoiding meals too close to bedtime, because if gastric contents have not adequately moved on from the stomach, these will, of course, create a situation where reflux could occur when a person is sleeping. In relation to sleeping, because of the anatomical structure of the stomach and the esophagus, the way they are aligned, it's probably better to sleep on the left side rather than on the right. The right side sleeping may cause reflux to occur more easily. Of course, managing stress and anxiety, as I'm sure you're aware, are important. Reflux-like symptoms are known to occur when we go through a period of stress and anxiety. Importantly, because I know that PPIs are frequently used at pharmacy level the world over, if a PPI is not effective, evidence would indicate that there's probably little to be gained from simply switching the doses or switching the PPI from one type to another. Of course, this may help in certain situations, but by and large, this is not a move that has been proven to be effective in very general terms. And of course, we do need to consider antacids and alginates for the management of the patient, and antacid-alginate combinations are available and have been shown to be effective. So to summarize, this is a very short session. We need to ensure that the patient presenting with these symptoms does not have any alarm or red flag symptoms or signs. We've mentioned them, things like weight loss, vomiting, a feeling of dysphagia or food sticking, and so on. It's important to ascertain that the symptoms are due to reflux and not another cause. So if, for example, the symptoms are made worse by exertion, it's important to ensure that the cardiac side of things has been considered. Do consider non-acid causes of symptoms. We mentioned hypersensitivity and the fact that only a proportion of patients with these symptoms are actually suffering from an acid-related problem alone. Please do offer preventative advice, possibly with an advice leaflet if you have access to one, maybe one that you can create yourselves. If over-the-counter medication is provided by yourselves, please consider an antacid alginate, and these are now available in combinations. And as I've said earlier, if a patient is taking a PPI, there may not be much to be gained by switching preparations or doses, but what you could do is, in addition to the advice that you've provided, is to consider alternatives like the ones we've just mentioned. And of course, finally, if you're not sure, and if the patient's problems persist, if the symptoms don't seem to be alleviating and the patient is still complaining of these symptoms, please do refer them to a doctor quickly, just in case there is something worrying that needs to be dealt with in a different way. So So that's all we need to cover today. Thank you very much.